Your voice is not audible.
Hello and welcome to this important conversation navigating migraine with experts, not assumptions. Together against migraine towards tomorrow. An initiative by Voice of Healthcare powered by Amneal Healthcare. I'm Simran Chaudhary from Voice of Healthcare here to host this particular session. When we talk about migraine, which is one of the most common neurological disorder, yet it remains one of the most misunderstood for many people. It is still seen as just a headache when in reality, migraine can significantly affect a person's health, emotional well being, productivity, relationships, and quality of life. Despite its widespread impact, many people continue to live with migraine without receiving the right diagnosis, appropriate treatment, or adequate support. And that is why today we are bringing together leading neurologists to separate evidence from assumptions, facts from myth, and awareness from misinformation. Through this conversation, we hope to help patients and families better understand migraine, recognize when specialist care may be needed, and learn about the evolving approaches to migraine management. And it is my absolute pleasure to welcome all our distinguished speakers joining us today. I would just like to take a moment to introduce our extreme panelist, Dr. Naveen Kumar, Senior Consultant Neurologist at KIMS Hospital, Hyderabad. Welcome to our show, sir, and thank you so much for joining.
Hi, thank you. Thank you so much for having us.
Thank you, sir. Dr. Lakshya Jyoti, Senior Consultant Neurologist, Apollo Excelcare Hospital, Guwahati. Thank you so
Good
much for
afternoon, ma'am.
joining, sir.
Hello.
Dr. Avinash Kumar, Senior Consultant Neurologist at Gleneagles Hospital, Hyderabad. Good evening, sir, and thank
Yeah.
you so much for
Yeah. Good
joining.
evening. Yeah. Thank you for having me here.
Thank you, sir. Dr. Vaibhav Seth, Consultant Neurologist at Manipal Hospital, Kolkata. Good evening, sir, and thank you so
Well,
much for joining.
good evening, and good evening to all the listeners and my fellow colleagues. And let's welcome every one of us for this important session that we have for the migraine.
Thank you, sir. Thank you so much.
Thank
And
you, sir.
Dr.
Good evening.
Arifa Rahaman, Neurology Specialist, Grade 2 at Department of Neurology, ECIC, Medical College and Super Speciality Hospital, Hyderabad. Thank you so much, ma'am, for joining, and welcome to our show. Thank you everyone for joining us. Let us begin our session by understanding migraine beyond what we commonly assume it to be. Starting with, I would like to begin my first question to Dr. Naveen. So, we know that despite being one of the leading causes of disability globally, migraine is still widely misunderstood. How serious is the true clinical and societal burden of migraine today when we look at the current scenario?
Yeah. Good evening to all the listeners and co-panelists. So I am Dr. Naveen from Hyderabad. I work for KIMS Hospital. So basically, these days, as personally, we are seeing a lot of patients suffering with migraine. So a lot of data is now coming out from Indian studies also. Previously, we have data from Western world. Now we have a lot of data from Indian population also. So as per various studies, migraine affects about 15% of the adult population in India. And as per the 2019 data, it's almost like 2 crore people will be most likely be affected. It could be even more also. And high prevalence of this migraine is seen especially in women and in urban India. And if you come to the clinical profiles, and most of this data is collected from the rural tertiary care centers from India. And what it has shown is most of these patients, they suffer with severe fatigue, nausea, vomiting in about 50% of patients, and phonophobia and photophobia in about 40%, and vertigo in 20% of patients. And stress is supposed to be the most common factor, which is acting as a trigger. And noise has been found to be most common, another common trigger in these patients. So this is about the clinical aspect in the general public in our country. But when you think about the societal burden, what is the burden of migrant society? So what we can see is there is a lot of workforce impact. Suppose, let us say, especially in Hyderabad, a lot of software engineers, IT sector is there. About 7-8 lakh people are working, and I see really a lot of people not able to do their jobs and not able to attend their complete their projects because of this headache, and we are losing a lot of time. Productivity issues are there because of this migraine problem. And when it comes to the healthcare costs, healthcare systems, especially in rural India, when somebody is having migraine and they are not able to treat it or not able to diagnose early, it results in repeated headaches, and there will be a lot of visits are happening because of the headache for symptomatic relief. That again adding burden on the hospitals because they need to accommodate all these patients. That is one thing. And another thing what we can notice is if we compare with the Western world, so the trigger factors for migraine are this sunlight, noise, air pollution, stress. All these things are more in our Indian subcontinent when you compare with the European and US. So that way also high prevalence has been found in most of the Indians. And usually in India, it is affecting women. It's about almost 75 to 80%. It is affecting women between the age of 15 to 70. So another contributing factors what we can see in our country is because there is underdiagnosis, there is undertreatment. That is one thing. Apart from that, there are a lot of disparity in the availability of doctors from rural and urban areas, and there are also socio-economic and cultural things are also being added because in certain parts of our country, homeopathy and other alternative medicine will be practiced in most of these rural areas, and they don't have much exposure to the allopathy. So traditional medicine is there in most of our states. So when it comes to the implications, how it is affecting, so basically we need to have a lot of public health campaigns, public health education needs to be done. And while we deal with this migraine, policy-driven approach has to be there, where we should incorporate this traditional medicine with the conventional medicine. I think it's not like what we should do in they do in Western world. We should have our own approach while in approaching this migraine problem because of our socio-cultural background and different. I mean, different states have different patterns. So that's it. I think the burden is increasing year on year, and I think uh, going forward, I mean, government also has to intervene, and people like us have to help in formulating the policy and help the government make up the policy. That's what I feel.
Thank you. Thank you, Dr. Naveen. You have explained us in a very well manner that what exactly is the clinical symptoms and how it is the what exactly is the current scenario and the treatment options as well. As you're moving ahead, my question is to Dr. Lakshya. So misconceptions can often influence how people perceive their symptoms and whether they seek care or not. So what are the most persistent myths surrounding migraine that continue to impact timely diagnosis and evidence-based treatment? If you could help us understand this.
Yo,
Dr. Lakshya, my question is to you.
okay. Actually, I was got disconnected. So,
I would just repeat my question that if you
yeah,
could help
yeah,
us understand the most persistent myths surrounding the migraine that continue to impact timely diagnosis and evidence based treatment.
yeah. So, yeah, it's a very relevant question actually. So one of the biggest myths is that the migraine is a simply a severe headache, but in reality, it's a complex neurological disorder, and that can involve abnormal sensory processing, cognitive and CI abnormalities and autonomic symptoms, and it can significantly impair individuals' daily functioning. So that is one of the most common, biggest myths. The second myth is that migraine must be associated with an aura, but the most patients with a migraine they don't have aura, so they don't necessarily have an aura, and that's we also frequently have patient level as migraine patient level as a sinus headache or cervicogenic headache, when actually underlying mechanism or underlying disease is actually a migraine. So the last myth is, according to me, the misconception is that um, migraine can simply be tolerated with repeated painkillers, but that leads to a vicious cycles of medication overuse headache and medication overuse headache and chronification of the migraine, and that is associated with a lot of use of resources, financial burden to the individual and the family, and finally, we assume that the migraine is a woman's disorder or something that will automatically disappear with advancing age. So both of which actually contribute to underdiagnosis and undertreatment of migraine patients. So these are the, according to me, these are the common myth that is relevant to today's discussion in regards to migraine. Thank you.
Thank you, sir. Thank you so much for answering that question, and letting us know about the myths which delay in timely diagnosis. As we are moving ahead, my question is to Dr. Avinash. So, taking that forward, we often hear about the significant prevalence of migraine, but the real concern is how many patients may still be living without appropriate diagnosis or treatment. Because we know with migraine prevalence in India, which is estimated between 14 to 20%, why do so many people still remain underdiagnosed or undertreated? So you're on mute, sir.
So I think now it's audible, right?
Yes.
Yeah. So good evening to everyone. I'm Dr. Avinash Kumar Addoju from Fortis Gleneagles, Lagdi Kapul. So the answer to my question is because I feel migraine is the tip of the iceberg. So many cases are still underdiagnosed or not diagnosed because most of the patients they go and self-medicate them. Headache हो रहा है, they go to the nearby pharmacist, they pop up some pills and they keep on postponing the diagnosis. And second thing, what I feel is all the doctors who are at base level, they also assume normal headache as any other tension type headache, which is not. Now the migraine is surpassed tension type headache, and now migraine is now considered as the most common type of headache among all headaches, among all primary headaches. So it's the tip of the iceberg which has to be uh, diagnosed, and the primary care physicians, the duty doctors, all the MBBS students also have to be uh, teach or taught about migraine, the atypical features of migraine, like associated with nausea, vomiting, photophobia, phonophobia, and the response. Many of them assume that there are no treatment strategies not developed for migraine, and everyone assumes that migraine is like lifelong disorder or disease. So these are the myths which has to be broken, and I feel that is the reason migraine is still very much underdiagnosed. Thank you.
I truly agree, sir. I think because of one, awareness is not there. Second is, just taking any
They
painkillers and stuff.
painkillers, and yeah, they postpone
Yeah.
it.
Stuff
Yeah.
like this, I think they don't pay much attention to it and just try to suppress the pain. I think that's what one of the important factor which you have highlighted is uh, a factor for underdiagnosis and undertreatment. My next question is Dr. Vaibhav. So early recognition can potentially make a significant difference in how patient navigate the disease. So from early recognition standpoint, what symptoms or patient pattern should clinicians and primary care provider be more vigilant about when it comes to migraine?
Okay, thanks for the question. I hope I'm audible.
Yes, sir.
Yeah, so I'm Dr. Vaibhav Said. I'm consultant neurologist at Manipal Hospital, Calcutta. So, talking about early recognition of migraine is very important. Like, for example, if we talk about the most common type of headache, it's not migraine. The most common type of headache is tension type headache. But when you come to the most common disabling headache, then it is migraine and not the tension type headache. So if your headache is disabling, that will bring you to the attention of the neurologist or to the physicians. But what is happening around is with the ability of over the counter medicines, you are popping the painkillers without consulting a doctor, and what happens is your pain cycle gets worsen, and what you are just taking is only the acute medicine for the migraine, and that even makes your migraine worse because you are at risk of developing migraine overuse headache. So when we actually talk about the early recognition of migraine, it is very important thing for the physicians to look beyond the headache. We should be particularly vigilant when the patient has recurrent stereotyped headaches with sensory sensitivity. What do I mean by that? The patient is having light sensitivity, patient is having sound sensitivity. The patient says that when the patient is having a headache, they like to stay in a dark room, they like to stay aloof from the light, and they want to just take a nap. So migraine can often present in a lot of way. We have auras, we have migraine without auras. Now auras are basically symptoms what you can see something like a scotoma, something you can see a zigzag line in your visual fields. Sometimes you can see a colorful objects in your visual fields. So these are some of the important symptoms that you should be aware of, and the primary level physician should be aware of that whenever you are getting these symptoms or other migraine needs to be controlled. And we should also recognize, like I mentioned about the medication overuse headache, so we should also recognize those patients who are becoming increasingly dependent on the acute medicine that we use for the migraine. For example, we have a number that if the attack is more than 15 times in a month for more than 3 months, then by definition we call it a medication overuse headache. So these patients are actually very difficult to deal with. And coming to that, it is does not end here. The recognition of migraine does not end here. What you have to do is you have to think beyond migraine also. Someone who is a chronic migraine, sometimes you might have change in pattern of your headache. So that can be marker of a secondary headache. Say, for example, I have a patient who is a long-standing migraine from 10 years, but suddenly your headache character changes. You have a thunderclap headache. You have a very bad headache, and people are aware if you're having a sudden thunderclap headache, then it is a marker of something called as a subarachnoid hemorrhage. So you should be aware of certain red flags, like for a patient who has underlying headache disorder. If there is a slight change in pattern of your headache, if you're having some systemic signs like fever, weight loss, or if you're saying that you're with the medicines your headache is not going, then it's time that you understand these red flags and think that superimposed on your primary headache disorder you might be having certain secondary headache. So the key message is to recognize the pattern and ask about the associated symptoms and triggers, and you identify the red flags. And early diagnosis per se means that you do the effective treatment and potentially treat the migraine, and like make it should not become a medication overuse headache.
I understand, sir. What you're trying to explain here is because, like you said, in terms of the pattern, in some terms of the symptoms, which a person should be very vigilant about. I think they just tend to ignore it, maybe because of could be another headache due to stress, due to some other factors, and I think that's what makes it more it difficult to recognize and more it makes delay for the treatment aspect also. As we are moving ahead, my question to Dr. Arifa, ma'am, even when symptoms persist, as we just spoke about, individuals continue to manage them on their own. So, they heavily rely on over the counter medication and delayed consultation. What systemic and behavioral factors are contributing to late presentations in migraine care whenever you encounter with patients, and in terms of the experience, how you're dealing it with patients? Can you hear me? Ma'am, am I audible to you? Dr. Arifa, can you hear me, please? I cannot hear you, ma'am. We request you to kindly rejoin as there's some problem. I cannot hear you. Can you hear me, ma'am? No, ma'am, I cannot hear you. I'll quickly move ahead with my next question. Um, as we have discussed about the basic understanding of migraine, the signs and symptoms, and what could be the why we are having delay in recognition, I would like to ask my next question, Dr. Naveen. So, our understanding of migraine has changed significantly over the years. So, migraine has evolved from a vascular disorder to a complex neurological disease. What major scientific advances have shaped the current migraine management?
Yeah, there is a lot of
Your voice is not
research.
audible.
I can hear you, sir.
Am I audible?
Yes, sir, you're audible.
Yeah. As you rightly said, so when about 15, 20 years back, when we were doing our post graduation, we were taught about the vascular theory. So that means whenever there is vasoconstriction, you get an aura, and when there is vasodilatation, you will get a throbbing headache. That was the theory which was used to be there. But now it has changed from vascular to neurovascular. So now we say migraine is due to a possible neuroinflammation. It's a neurological mechanism which is happening live and resulting in the increased blood circulation to the brain and thereby causing headache. So in about till 1990s, so only paracetamol and ergotamine preparations were available. Maybe around 1992, at that point of time, sumatriptan was introduced in USA. And in 2005, we were getting subcutaneous sumatriptan. We used to give that in those days. So subsequently, for almost for 25 years, triptans are the only drugs which were available in the form of either subcutaneous or nasal. This thing used to take it like a nasal puffs. But from 2019, after that, from 2012, there is a lot of research which is going on in the field of migraine, and they have found that scientists have found that various markers like peptides like interleukins, TNF, nitric oxide, CGRP, PACAP. I mean, a lot of peptides have been implicated in the pathogenesis of migraine because there is overexpression and excessive production of CGRP, which finally results in the dilatation of blood vessels, thereby leading to intense throbbing headache. That is the basic recent mechanism which has been postulated.
Simran,
And there are certain
voice is not
treatments.
audible.
So
It's not,
we can hear Dr. Naveen properly, so
yeah. So now the concept has changed, and based on this concept of increased release of CGRP and increased expression of CGRP receptors, many novel pharmacological targets have been identified, and many new drugs have been identified. The most recent one is the monoclonal antibody, Erenumab, which is there from 2018 in Western countries, and last 2 3 years we are even using it in our Indian population also. So basically, these drugs they block the CGRP receptors or the CGRP directly. And apart from this, we also have oral Gepants like Ubrogepant, Remigepant, which is now available in our country. Even though they are expensive, they are still available, and they also block the CGRP pathway. And there are other group called Ditans, Lasmiditan, which was approved, but because of some side effects, nowadays we are not using that tablet. And emerging therapies, when a lot of trials are now ongoing, there are antibodies being produced against PACAP and nitric oxide receptors. Maybe in the next 2 to 3 years, phase two trials are going on. So we may be able to see a few more products coming in this direct targeting of the pathway. So that is one thing. Another interesting field, what's happening in migraine is precision medicine. Suppose previously, about 10 years back, it was genome analysis. It was costing about 1 lakh. Now it has come down to 20,000. Now in Hyderabad, we are able to do it 10,000. So once we start doing genetic genome sequencing, either whole exome sequencing or whole gene sequencing, once we have a repository, we can link different genes to the migraine. And once that is done, maybe we will have a genetic profiling of all the people, and we may be able to we maybe come to a stage where we can say which drug will work for which migraine patient. So we are going in that direction. Maybe in the next few years, we might go for a genetic testing, And based on that, we might be prescribing medicine. That is one very recent advance and optimistic advance which is happening right now. And apart from this, many non-intervention, non-medication related, non-pharmacological innovations are also happening. In US, we have Nerevio, we have Cephali. Many devices are there, remote electrical neuromodulation. They just wear it like a band, connect with the phone. It will keep on stimulating, and thereby it could be a peripheral stimulation. You can stimulate your hand. Sometimes you can stimulate your head, trigeminal nerve or occipital nerve, which results in a reduction of your headache uh, frequency and severity also. So right now in India, these modulatory devices are not available. Only transcranial magnetic stimulation (TMS) that is available, and few centers are actually doing it. They are seeing some results are plus or minus. Some patients are responding, some are not responding, but there's a long way to go. Many few more neuromodulation devices are being developed, and probably in future they will come to use. And apart from this, many phase two trials are underway, and antibodies against newer inflammatory markers are being developed. So a lot of things are happening. A lot of research, fascinating research is happening in the field of migraine, and ultimately it is shifting towards the symptom treatment to a pathogen mechanism based treatment, and it's also going towards personalized treatment. Who knows, maybe after some time we might get a gene therapy also, the gene which is producing the CGRP or PACAP, and if we can target that gene and if we can introduce that gene, maybe it might cure migraine also. That is the level of understanding which is being developed in migraine, and future is going to be optimistic. And I think we are going in the right way, and every year we will be seeing this new type of drugs in the coming years, and that's what I feel. Yeah, we are in an exciting time.
Thank you, sir. Thank you so much for answering that. And we are also looking forward to such innovation, such new optimistic therapies which can come and we can have a better management of migraine. I would just like to take my question to Dr. Arifa, if we have Dr. Arifa here. Okay, I guess ma'am is not here. I would just like to move ahead with my next question to Dr. Lakshya. So, one of the significant development in recent years has been the emergence of therapies targeting CGRP. So, CGRP targeted therapies are being viewed as a breakthrough in migraine treatment. So, how are these therapies changing the preventive care strategies and the patient outcomes also? So, you're on mute, sir.
Okay, Simran, that's a very actually good question. CGRT treatment actually replaces from previous non-specific
So
mechanism based.
we cannot hear you clearly, sir. Your audio is not clear.
Yeah, am I audible?
So
Hello.
it is little muffled, but we'll try to have a better. Yes, sir. If you can can be a little
Yeah,
louder, please.
yeah, yeah. So CGRT targeted treatment represents an important paradigm shift from non-specific preventive therapy towards mechanism-based treatment in the field of migraine. Am I audible in the field?
Dr. Lakshya, we cannot hear you clearly.
Okay. Maybe
So there is a lot of noise. We cannot hear you clearly, or we cannot make out what you're trying to explain to us.
okay,
I request you to kindly
okay, I'm
join
sorry.
with better network. I would like to take
Yeah,
this
yeah.
question from Dr. Arifa. Ma'am, are you here with us, please? No, ma'am, is still not here. I'll move on to my next question to Dr. Avinash. So, with the patient experiencing migraine differently, the idea of individualized treatment is becoming increasingly important. So, how feasible is precision driven migraine management today, particularly in tailoring therapies based on patient phenotype, trigger, and disease pattern?
Yeah, if you see migraine patients, there's certain typical phenotypes. They We have to give them different medications. For example, if the patient is we have to identify what are the triggers. Like for example, many of the patients, what we see in our clinical practice, they have lack of sleep. So lack of sleep triggering migraine. So we have to individualize whether he is a night shift worker or not, or whether the sleep pattern is appropriate or not. That sleep cycle, whether if he's maintaining the sleep hygiene, is of utmost importance. And tailoring treatment regimens according to the lifestyle of the patient. Most of the patients, if they are having severe multiple recurrent headaches, then keeping them on beta blockers helps reduce their headaches much more better. And if the patient is obese and they're overweight, then probably starting them on topiramate will give them much more relief. And if the patient is having underlying mood disturbance, uh, then probably we have to add them on sodium valproate as well. So depending on their phenotypes, the treatment regimens can be tailored. Yeah, thank you.
Thank you, sir. Thank you for explaining us that. I would quickly move on to my next question to Dr. Vaibhav. So, technology is also creating a new possibility in diagnosis and monitoring. So, when we talk about biomarkers, so what role can biomarkers, neuroimaging, digital health technologies play is enabling a more accurate diagnosis and a long-term treatment monitoring also?
Okay. So I'll take this question in three parts basically. So you are asking about biomarkers, you're asking about neuroimaging, and you're asking me about some wearable technologies. So a lot of thing has been covered by the other speakers also. Like Dr. Naveen mentioned a lot of thing about CGRP, and one of the molecules that are newly coming up is the PACAP, which is the pituitary adenylate cyclase, the peptides. So commercially, if you ask me for migraine per se, right now we do not have any commercially available biomarkers that can actually diagnose the migraine. But migraine is more of a clinical diagnosis. But what research is going on right now? The research is now going on, as pointed out by our speakers before, that we have been moving from the vascular theory to the theory involving the trigeminal system. So right now, what happens is during the migraine attacks, certain neuropeptides are on the rise. So maybe someday down the line, we would have these blood tests available in for the commercial purpose and for the patients, where you would be measuring the calcitonin gene-related peptides or the PACAP levels. So this is to your biomarkers. And coming to the neuroimaging, I mentioned in my I mentioned in my talk before that we usually do not do imaging in a patient of migraine until and unless I'm thinking of something secondary headache that I'm thinking in patient of migraine. So if you're thinking that this headache pattern is kind of different from that of a migraine, or are you getting any red flag signs like maybe some systemic illness is there, or say a pregnant patient with a background of migraine now throwing a different pattern of a headache, these things are like an urgent indicator that you need to do neuroimaging. So the neuroimaging role in a patient of migraine in one line is just to rule out the dangerous causes of headache, which is basically the secondary headache. Now, how digital health is evolving in the migraine. Now, what is very important is when our migraine patients they come to us in the OPD, we always tell them to maintain a headache diary. So in headache diary, what do you maintain is you mention the dates, you mention the time when you are having the headache, you mention about the symptoms that you have associated with the headache, you mention about whether you take the acute medications or not, or sorry, or what were the associated triggers. And looking into the diary, a consultant or a headache physician can actually see, can gather a lot of inputs from that headache diary. You can
Yeah.
you can get to calculate the monthly migraine days. You can calculate the number of time the acute medicines are used. You can get the time. You can get to know whether your preventive medicines are getting useful or not, or whether they are actually reducing the number of attacks, or whether they are making the headache to the patient less disabling. Because ultimately, that is the target of our management. But now with the latest technologies that we have, sometimes we have headache diaries, we have smartphone based applications that can capture the headache, that can capture the frequency, severity, triggers, and it can also, correlate with the menstrual and the sleep irregularities that are part of the migraine triggers. And wearable devices are also available that provide additional information about the sleep activity and the physiological patterns. So, while biomarkers and advanced imaging are largely in the research, but this digital monitoring is actually helping us move towards more objective, longitudinally, and a personal care that we can provide to the migraine patients. Thank you.
Thank you, sir. Thank you. You have explained us very clearly that the role of the biomarker is not yet available for the migraine and neuroimaging. Where do we and when do we use neuroimaging? And yes, there's still health technologies and maintaining a migraine diary, which we call it as a logbook, will definitely help not only patient but also the clinician to understand when are these episodes occurring, and what is exactly triggering them, and accordingly the clinician can help a patient to manage all these symptoms. So as we're just discussing about this, the how we can manage it and what signs could, what could be the triggers. I have a very similar question from my audience, if you could help us answer this. uh, the question is, whenever weather changes suddenly or it gets very hot, I sometimes get a migraine. Is there a connection between weather change and migraine attacks? Dr. Vaibhav, if you can help us understand this.
Absolutely, absolutely. This is one of the, very good question that has been asked by the audience. So, if you see that the weather changes, sudden changes in the weather is one of the trigger factors for migraine. And what happens, we see a lot of patients of migraine coming with an acute attack during your summer season, or just during the change in weather when the summer is about to go and you get the rainy season. So this weather patterns basically causes the change in the peptide levels in that is affecting the trigeminal system, and it causes the attack. So what I tell to my patients that whenever there are these weather changes, most of the time what happens is the patients, they become complacent. So you have been on your migraine preventive medicines starting from winter to spring and you are fine with it. So and suddenly when there is a change in the weather, you start to get an acute attack because you have already stopped the preventive medicines and you have become complacent. Many a times people are not carrying their acute medications. A simple naproxen if you carry during your trip also, and if their weather changes and if there is an acute attack, you can simply abort the acute attack because the cause of attack perpetuating is the attack has not been aborted in time. So that's why it is very important you identify the triggers. Once you know that the weather changes are your triggers, you become extra cautious. You take more precautions. You are ready for the attack to come.
I think so. You have cleared this doubt of our audience, which the person has asked, and thank you so much for clearing this. That why this happens, in specifically when the weather changes, and what could be the reason behind it. Thank you for taking that question, sir. I'll move ahead to my next question to Dr. Arifa. Ma'am, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, ma'am. Yes, we can hear you. Ma'am, I would like to know that migraine management is not only about medication. So, beyond pharmacological therapies, which lifestyle, behavioral, or integrative intervention currently have the strongest evidence in improving migraine outcomes?
Thank you, Simran, for that question. So, as my previous speakers have already explained about the triggers of migraine. So, so every patient have different triggers. So, one thing, the most important thing for every migrainer is to identify the triggers of the migraine. So, some have, like already mentioned, heat as a trigger. Some have food as a trigger. Some have decreased sleep as a trigger. So every migrainer have their own triggers which they can identify by themselves, and preventing these triggers is one of the lifestyle modification which can be done to prevent migraine. So our primary aim in all this is prevention of migraine attacks and increasing the working days, active working days of the person who has migraine. So one is lifestyle modification by identifying triggers and avoiding the triggers. Like some even have, if they have dehydration, they have migraine. So maintaining the hydration, and some foods whichever are triggering your migraine can be prevented. So these are the lifestyle and behavioral modifications which need to be done by a migrainer, along with the medications of both preventive and acute management, that will help the patient to overcome the number of migraine attacks. So, along with the medication, the lifestyle modification, weight management is also one of the things which helps in migraine prevention. And understanding the migraine by maintaining a migraine calendar, and what is in females mainly, some have migraines around the menstrual cycle.
Hmm.
So during that time, having your acute medication in hand, if it is only during that episode, and if the migraine has become chronic, then starting your preventive therapy also. This integrated approach of both your trigger management, your acute management, and your chronic management will help the patient to decrease the migraine days and improve the overall activity during. Can you hear me? Sorry.
Yes, ma'am. We lost you in between, but yes, now it is clear. Um, Ma'am, you have answered us very clearly that how it affects patients and what all weather changes, menstrual cycles, and other factors which affects it. Very similar to what you have explained us right now. I have a question from my audience. I would just like to present that, which says that I sometimes get a severe headache with nausea and sensitivity to light, but it goes away after few hours. So how can I know if it is actually migraine or just a normal headache? Dr. Arifa, if you can please take this and help us understand.
Sure. Yeah. Migraine headache usually lasts for few hours, and whenever there is photosensitivity and association of nausea, it is definitely a migraine episode, because migraine typically have these pre-dromal symptoms that patient understands he is having, he might get a migraine attack. Then after a migraine attack starts, then the nausea and photophobia and phonophobia added to it is definitely a migraine attack. And
Thank you,
another
ma'am.
thing is
Yes, ma'am.
during the migraine attack, how severe it is and whether it is getting down with medication also will help us to understand whether it is a migraine attack or not.
Thank you, ma'am. Thank you so much for taking this ahead and clearing the doubt of our audience. As we move ahead and focusing more on regional burden of migraine and policy advocacy, I would like to ask my next question, Dr. Naveen. So, starting with the geographical perspective, are there any notable regional variations in migraine prevalence, environmental triggers, or healthcare access across the different parts of India? Sorry, you're on mute, sir.
Yeah. I'm unmuted.
Yes.
Yeah, that is an interesting and important question actually. So we have so many states, so many weather patterns. So definitely in our country itself, there will be a lot of variations when we see across the country. So let us say a lot of studies are there, even prevalence studies. So what they have found is in 2025 there was a meta-analysis done, and overall prevalence of migraine is about 18 to 19%. So general population it is about 20%, but when they have analyzed only student population, it comes to around 12%. And in few communities, it is only about 3 to 4%. In some areas, it is about 35 to 45%. So much variation in prevalence is there. I mean, the number of people who are affected. Imagine in certain communities, about 40% of people are having migraine in some at some point of time in their lifetime. So that way, there is a lot of difference in the prevalence uh, across the country. And coming to the environment, you said, suppose if we divide it like in North India and South India, just because above the latitude and below. I mean, in the North India, what they have found out is stress and noise are supposed to be the most common trigger factors. And when it comes to the South India, different studies have shown that sun exposure stress, lack of sleep, and travel. These are the main factors which are affecting causing migraine. So if we analyze this, what we can see is in southern India, most Hyderabad is there, Bangalore is there, Chennai is there. So most of the tech world is focused here. In northern India, I mean, computer science. I mean, these are a little bit less when compared with these major metropolitan cities. So once the technology companies are more and the jobs are more in the tech sector, their exposure to laptop systems, everything is more in the South India. So that might explain why they are having anxiety, insomnia are the main culprit factors in South India. And sun exposure is also more, especially when we go to the coastal region. As one audience has actually put a right question whether any weather will contribute for the migraine. So the atmospheric pressure itself is one trigger factor. So if you go to the coastal regions, humidity will be more. Humidity itself is one of the trigger factor. What they have found is a lot of migraine cases are there in the hot, humid conditions. So, so that environment will affect us in that way. And another thing is healthcare access and management. If you go to the rural India, there are only not many doctors are there in the rural India actually. Most of them are in tier 2 and tier 3 cities. If you go to the tier 3 and villages, only local some unqualified people will be there who will be giving medication. They will be giving only some painkillers. So people don't have village people don't have access to a specialist or a GP or so. Forget about neurologist, they can't access even a physician, especially in the villages. So obviously, when they get headache, they will take a simple painkiller which is available in the shop, and it keeps on. Migraine keeps on adding. Central sensitization happens. It will evolve into chronic migraine. So this rural and semi-urban and urban divide is there significant factor in India. So what are the implications? So we have seen that now there are difference between North India, South India, from urban to village, different populations, migraine variance is there. Why it is important is whenever you are planning a policy, suppose your government wants to have a policy against migraine, they can't just go with a single standard policy like other countries. So we have to in different areas have different prevalences, different regional factors, different traditional systems are there. Certain communities they only take Ayurvedic medication. Certain communities only take homeopathic medication. So to go and tell them that this medicine in allopathy works, it's a difficult task. Initially there will be denial; they will not accept it. So we have to sensitize. A lot of public education is needed. Government has to put a lot of effort. Region-based protocols have to be education has to be developed. Region-based trigger factor identification has to be done, and we have to educate the public about how to reduce those trigger factors. And we have to educate the practitioners who are in the rural area as well as the primary physicians also need to be educated well about the different new things which are happening in field of the migraine apart from the public education. So if we can do all these things, then only migraine can be diagnosed early. And once we diagnose early, the headache days will come down and visits to the hospital will come down. Health system, burden on the healthcare systems will come down.
Yes.
I think it needs a coordinated effort, and each state should work on individually and come to a reasonable conclusion. Yeah, that's what I feel.
Thank you. Thank you. So I think you have explained us very well the difference between North and South Indian and how the factors could differ and what could be the triggers in when we talk about the different parts of our country and what exactly is the triggering factor. My question is Dr. Lakshya. So, like a bit of thing has been answered by Dr. Naveen only when we talk about lifestyle and environmental factors and increasingly becoming part of our conversation. So, how are urban stress, pollution, changing lifestyles, and workplace pressure is influencing the growing migraine burden in the younger populations also?
Hi, Simran.
Yes, sir. We
Can you
can
hear
hear you.
me?
Can you hear me? Yes, sir.
Yeah. So this is a very important question. For younger patient, I think we increasingly see migraine occurring in the setting of multiple interacting lifestyle pressure rather than one isolated trigger. So here the stress is most commonly and reported but is often accompanied by irregular sleep, skip meals, excessive screen exposure, and prolonged working hours, reduced physical activity, sedentary activity, and inadequate hydration. These are the part along which comes along with the stress. And another important thing is nighttime digital exposure. Nighttime digital exposure is particularly relevant because it disturbs sleeps, and the irregular sleeps can itself can lower the migraine threshold. So the another area of interest is air pollution. This observational evidence and studies have shown that the association between exposure to pollutants and such as particulate matter, carbon monoxide and nitrogen dioxides, and uh, nitrogen dioxide and migraine occurrence, but still we need to establish the causality of between these particulate matters and gases to the migraine occurrence. And but in clinical practice, therefore, I do tell my patient that uh, to, I don't really tell them just to identify a dozen of triggers for migraine or trigger for migraine. Instead, I tell them that I focus on stabilizing the migraine threshold by regularizing sleep, regular meals, hydration, exercise, regular exercise, sensible, uh, sensible amount of screen use, and stress management. So I usually advise that you don't particularly point out a single stressor. So that is usually more sustainable than the excessive avoidance behavior, because once the person starts knowing that okay, stress is the most common stressor or risk factor for developing migraine or aggravate migraine, so they tend to develop an avoidance behavior. So I don't recommend that. So instead of looking for a dozen of trigger, I just ask them to stabilize the threshold by regularizing sleep, regular meal, etc. So that is what I want to say about the urban situation, pollution, and changing lifestyle in regards to migrant.
Thank you, sir. Thank you so much. I think we all would agree that yes, lifestyle factors, environmental factors can be a very big trigger when we are talking about the triggers of migraine. And yes, managing them will definitely help us. My question is, Dr. Avinash. So, access to specialized neurological care can still be a challenging, problem outside major urban centers. So, what are the key healthcare delivery gaps still exist in ensuring equitable migraine diagnosis and treatment across tier 2 and tier 3, and more specifically towards rural regions? Dr. Avinash, are you there? So, you're on mute.
Yeah, hope it's audible now.
Yes, sir.
Yeah. So, as India is a developing nation, we still have many gaps to be filled because out of these tier 2, tier 3 cities, as Naveen sir has rightly depicted, there is availability, no availability of primary care physician in some villages. So, strengthening the referral system and teaching the primary care physicians about the migraine and typical features of migraine would help a lot. And everyone what we're talking about stress, but stress primarily comes from not working adequately on their work. So when so we have to teach them in their respective fields to do adequate work in respective fields, whatever work they are doing, so that the to avoid stress we have to increase the threshold has to be increased. So we have to teach the primary care physicians to diagnose the symptoms of migraine, and as well as the whoever the patients are suffering from migraine, we have to teach them to raise their own thresholds. You got my point?
Yes, sir.
And strengthening the referral system, as I already told, and mediating or implementing digital diaries to use, that also helps, and telemedicine also helps because tier 2, tier 3 cities, patients cannot reach all the doctors. So you should arrange a helpline where the patient can ring up if they're having headache. And probably they should involve a national health mission policy on migraine for a developing country like India, so that easy access will be there. Just a phone call away, the symptoms are diagnosed, and probably the beta blockers and the calcium channel blockers, which we commonly use, those medications should be available at the government sectors as well. So by doing this, the gaps and bridges can be covered, is my opinion.
Thank you, sir. Thank you so much for sharing your insight on this. Dr. Vaibhav, considering the broader impact migraine have on individuals and society, so, impacting on productivity, mental health, quality of life, so should migraine receive stronger recognition within national health and non-communicable disease framework? If yes, then why it's so?
Yes, I absolutely agree with the fact that migraine should be receiving a stronger recognition in the national public health and in the NCD frameworks. Why, I'll tell you, because it's just not simply a headache disorder. When we
Yes.
see migraine, we are not restricting ourselves to headache. Let's first talk about the disability that it brings with you. And I might be speaking something that would also be very controversial, but that's a fact. So we have to take that. So migraine, as I say, is not simply a headache disorder. You just cannot measure migraine in terms of headache days. That's one thing that we measure in the clinical practice. But what about counting the fact number of absenteeism in your workplace? What
Yes.
about counting the fact living with the headache and losing the productivity at your workplace? Counting the fact, the cost, and the financial burden that comes with it. We all are doctors here, and there are a lot of people listening to us. So you do a poll and find out how many patients would take medicines for their migraine attack, acute attack, I'm talking about. The oral medicines are not working. At that point of time, the headache has gone into such an extent that it's about to become status migrainosus. You are vomiting like anything, you are not able to take any medicine. So you land up in emergency where you are given some parenteral therapy and you would like to get admitted. But what happens at the end? There are a lot of insurance that deny admission to migraine and they say that it's a migraine. So you were just
Yes.
admitted for some evaluation or something like that. And what happens in the end? You have to pay the money entire from your entire own pocket. So what is the point in having a medical? So there should be a strong rule like this discrimination should not be there. If you are admitting a patient for fever, you are giving the claim for migraine, at least it should be there. And I think most of us have faced this and nobody would deny to this fact. Then talking about some other points like migraine coexists with other disorders also. So when you're just looking at the migraine, someone just mentioned, one of our speakers mentioned, that it is the tip of the iceberg. You are not looking into the anxiety, depression, insomnia, and other comorbidities that comes with it. So it's just not about treating the migraine. You have to you we are underestimating the true burden of this disorder in the as far as the public health is concerned. And we need to measure the lives productivity and the quality of life that migraine takes away from a patient, and that's why it makes it a priority at the public health level. We should be doing programs regular level. I mean, the government should be doing, the organization should be doing it to train the primary healthcare physicians so that they recognize what can be treated from their end and when actually the patient needs a referral. So the government should be equipped with facilities like speaker mentioned, that you should be having the drugs that are ready. So that's why it is very important that the lost productivity, absenteeism, and the healthcare utilization should always be there, and the caregiver burden that also comes with the migraine. These things also should be taken into account. So I very much agree to the fact that the integration into the national public health programs and into the non-communicable disease framework is the need of the hour. Thank you.
Thank you, sir. Thank you so much for giving us this amazing explanation that why this deserves a much bigger attention, and most likely to be part of the NCD, and the policy should be made around this. As we are coming into this discussion, I would like to take my question from Dr. Arifa. Ma'am, quickly, if you could help us understand that if you had the opportunity to bring about one meaningful change at the policy or the healthcare system level, and you could advocate for one transformative policy healthcare initiative to improve migraine awareness and access to specialized care in India, what would be that, ma'am? Ma'am, you're on mute, ma'am.
Can you hear me now?
Yes, ma'am, I can hear you.
Yeah. Thank you, Simran, for that question. I definitely agree with migraine awareness being the prime point to bring about change in the society's understanding of migraine, along with the lost days of work, which are affecting the productivity of the person and at the same time productivity at the workplace as well. So one change is we should start migraine awareness from the very basic level of primary healthcare, where the doctors at the primary healthcare centers are the primary persons who the patient uh, approach to whenever there is headache which is not coming down by over the counter medications. So in the villages, primary healthcare physician should be educated, and all the physicians should be educated about the migraine awareness and the hello, can you hear me?
I can hear you, ma'am.
Yeah. And the
Ma'am, you're not audible
and
in
the
between.
preventive measures of migraine and
Yes, ma'am.
sorry.
Yes, ma'am. Please continue, ma'am.
Mm. So the basic awareness should start at the basic level where everyone should be given uh, the diagnostic criteria or whatever these things should be kept in mind whenever the headache patient is approached to rule out migraine. And also awareness programs, video awareness programs should be done in a primary healthcare center also to understand, to make the people understand about the migraine and that it is treatable. And also a telemedicine would help because the specialist is not available at every center. A medicine from a local center to a specialist would really help the patient to get diagnosed early and treat.
Yeah, you're not audible now to us. Arifa, ma'am, you're not audible to us right now. I think there's some network issues. Um, I think we will take this as a message for the questions I've just asked. We got a good clarity around that why we need a good policy for the migraine management and the awareness, and a initiative for improving accessibility and specialized care in our country. With this, we have come to end of our discussion, and I would just like to thank all my panelists for sharing their expertise and perspective with us today on and what exactly we are taking away from this conversation is that migraine is not simply a headache. It is a neurological condition that deserves recognition, timely diagnosis, appropriate treatment, and the long-term care. And perhaps most importantly, awareness can really help patients move from simply tolerating the migraine to actively managing it. A big thank you to all the panelists present here, Dr. Naveen, Dr. Lakshya, Dr. Avinash, Dr. Vaibhav, Dr. Arifa. Thank you to all the speakers for joining us and sharing your valuable insights. This conversation, navigating migraine with experts, not assumption, Together Against Migraine Towards Tomorrow is an initiative by Voice of Healthcare and powered by Amneal Healthcare with the aim to encouraging awareness, informed conversation, and better understanding. This has really helped us to understand migraine a little better. We encourage you to share this conversation with your families and friends, everyone who you think can be a part of this and can really have get some benefit. Thank you, everyone. Thank you so much for joining. Thank you, sir. Thank you so much for taking out time and sharing your perspective from your busy schedule. Thank you so
Our
much.
pleasure.
Thank you.
Our
Thank
pleasure.
you, Simran.
Thank you.
Thank you all.
Thank you.
Thank you so
Thank you, respected colleagues. Thank you.
Thank you.